This is Team A's final presentation on creating a model to predict an individual's HPV vaccine uptake. Our goal was to create a model to predict an individual's likelihood of getting the HPV vaccine using the machine learning prediction paradigm. The HPV vaccine is incredibly important because HPV has been proven to cause a number of cancers, including almost all cases of cervical cancer. So increasing vaccine uptake will decrease cancer rates. The uptake is also low compared to other vaccines since the vaccine is relatively new. So it is important for policy providers and public health officials to understand who is not receiving the vaccine to target resources accordingly. Finally, there are $8 billion in costs a year related to HPV diseases, and increasing vaccine uptake will help reduce these costs. In order to tackle this problem, our team took 5 steps in putting together our model. First, we chose a data set, the CDC Behavioral Risk Survey. Next, we cleaned the data so that only those who would have been eligible to receive the vaccine when it came out were included in our data set. Third, we modeled the data, largely using decision trees and some logistic regressions. Next, we found that age and gender were the biggest predictors of vaccine uptake. Finally, we ran a few final iterations looking specifically at age and gender to further explore who in these groups were likely to receive the vaccine.
Some of the biggest predicting factors we saw across all models were age group and gender. With age group, older populations were less likely to have received the vaccine, which is consistent with the recent release of the vaccine. With gender, females were much more likely to have gotten the vaccine, which is consistent with the vaccine only being recommended for women in the first couple years of its release. Other factors, such as socioeconomic factors like number of children and education, popped up in several models, which is consistent with other health outcomes for these same populations. And then healthier attributes, such as getting a tetanus shot, getting a pap smear, or having a lower body mass index, were associated with getting the vaccine. We used AUCs as an evaluation method for all of our models. The full model with all genders and ages included or had an AUC of 0.735, and then you can see the other AUC scores here. Here's an example of one of our models of females ages 18 to 29, which is an eligible age range for receiving the vaccine still. We think it's interesting for policy purposes as it's the most likely group to get the vaccine, and so we wanted to know what specific attributes in this population are good predictors for not getting the vaccine. There are 2 classes, 0 is getting the vaccine and 1 is not getting the vaccine. If you've had more than 2 children, it's likely that you did not get the vaccine. And then having less than 2 children, we look at whether you've gotten a tetanus shot. And if you haven't gotten a tetanus shot and haven't received a pap smear, you're also likely to be in the group that hasn't gotten the vaccine. And so on with other indicators such as alcoholic drinks per month and week and your average weight.
This last model provided us context for some of our policy conclusions at both the public health and individual provider levels. First, because most men do not receive the vaccine, we recommend targeting all men with public health resources in order to counteract the early feminization of the vaccine when it was first released in the early 2000s. Additionally, many of our model's top indicators can be impacted by increasing access to things such as reproductive health and family planning services, specifically in lower income communities. And at the micro level, we recommend educating doctors on how to use our decision tree with individual patients. Our research shows the power of capitalizing on the effectiveness of doctor recommendations to patients. So if doctors know who is less likely to receive the vaccine, they can both recommend and direct their efforts to following up with those at-risk populations. Going forward, we recognize the need to continually update our model because of the effect of things such as state vaccine recommendations and school requirements, which will change the relationship of different attributes on vaccine uptake in our model. We would also want to find a data set that includes more state-by-state data and data for individuals under 18 years old. Neither of these things were included in the CDC data set and would provide additional insight for policy conclusions. While we obviously still have more steps that we would like to take, the models we have already created do provide some easy first steps for health policymakers at this time. Thank you for listening.